Thank you very much, and thank you once again for inviting me here to this outstanding meeting. But before I start, as I will discuss the transplant from very different angle of perspective of very unlimited resources and ex vivo perfusion. Before I start, I would like to express my respect and gratitude to both four speakers for outstanding presentations and outstanding job they do. And it only signifies how much can be in a landscape of limited resources achieved with tenacity, determination, and resourcefulness. So thank you very much for that. I really appreciate it. And I have personal experience from having my surgical rotation in India, so I understand the context, and I appreciate it even much more than that. Thank you very much. So let's move to my topic. I've been asked to address hemodynamic optimization in patients, in donors, potential donors for heart transplant, and also address the issue of ex vivo organ perfusion, which is obviously very resource-intensive technology, but with very excellent outcomes. So my disclosures. So here are three opportunities how we can utilize donor organs. Nonetheless, it's more than evident that in the case of heart transplant, so we have to focus only on donation after brain death or donation after a circulatory death, and I will focus on these two. So the first one is a very principle and simple, straightforward pathway from donation after brain death after donor hemodynamic optimization towards the transplant. So, or in the case of DBD or DCD, so we can also pursue more complex techniques of optimization of the organ, even ex vivo, by resuscitating organ, reconditioning organ, or transportation on a long distance. So, and here we can utilize two modes of ex vivo machine perfusion: normothermic oxygenated perfusion or hypothermic oxygenated perfusion, so which ultimately lead again to the heart transplantation. So here is the definition of a consensus statement from JAMA 2020, when brain death is defined as an irreversible loss of all function of the brain, including the brainstem. And the three essential findings in brain death diagnosis are coma, absence of all brainstem reflexes, and also apnea, further validated by graphical techniques such as CT angio typically. So this slide should demonstrate the complexity of pathophysiological changes related to the hemodynamic instability in donors or potential brain death donors, so which is signified by decreased preload, decreased contractility, and also decreased afterload. While after brief hyperdynamic phase of catecholamine storm with hypertension and arrhythmias is followed by prolonged hypodynamic phase with hypotension. And hypotension cause is typically vasoplegia, hypovolemia, cardiac dysfunction, and also notably endocrine failure, including diabetes insipidus and thyroidal dysfunction. And here it's all just underscored and mentioned that without appropriate hemodynamic stabilization and interventions, the changes lead to circulatory collapse within roughly 48 hours. So there is a limited window of opportunity for utilizing the organ. So in more detailed picture, we can appreciate that cardiac changes in DBD donors lead to sympathetic storm, hormones depletion, and also decreased coronary perfusion with ischemia, and lead to structural myocardial damage with myocytolysis, subendocardial ischemia, myocardial edema, and also interstitial infiltration with mononuclears. So with a result of brain death donors, myocardial injury accounting for almost a quarter of the patients, and myocardial dysfunction as high as 40% of these DBD donors, and also ECG abnormalities. So in a complexity, so we have to understand that the result and the function of transplanted heart is influenced by multiple factors, including donor characteristics and also obviously recipient characteristics. Further, the effect of of the burden of the brain death effect, organ retrieval, transplantation, and also organ preservation, and I will allude to this point further in my presentation, and very principally, aggressive and timely donor management, which is tightly interwoven with the brain death effect. So, and that's very essential. So if we take a closer look to the hemodynamic stabilization of the patients in terms of supportive management in BTD donors, so we have to maintain adequate mean arterial pressure, including use of vasopressors and inotropes if needed, treating hypovolemia, vasoplegia, and optimize ultimately cardiac function and organ perfusion. So here are very complex algorithms how to manage optimally hemodynamically the potential donors. I will not deep dive to the details. Nonetheless, here should be mentioned that the goals in general are to maintain hemodynamic status, to achieve normal volemia, maintain blood pressure, and optimize cardiac output in these patients. So, and now let me move from the hemodynamic stabilization in vivo of the organ to ex vivo oxygenated perfusion. So where the journey is a little bit more complex, as after unlike the single ischemia in cold preservation of the donor organ, so the journey is a little bit more peculiar, starting with the first ischemia, retrieval of the heart, and instrumenting the heart to the machine. Then the next phase is oxygenated blood perfusion, so which is very satisfactory in terms of conditioning the organ function, followed by the second period of ischemia once the heart is again arrested, pleached, and cooled, and the surgical transplant procedure ensues. So in principle, we have two techniques how we can preserve ex vivo the organ. We can use dynamic normothermic oxygenation, it's a system transmatics, or static hypothermic oxygenated technique. So further to the details, normothermic oxygenated perfusion uses perfusion with oxygenated blood, normothermic. The heart remains metabolically active and contracting while unloaded. The heart is perfused with oxygenated perfusate. So, and there are multiple senders which basically help to run and optimize the system and perfusion with autologous blood, which is collected from the donor, with using hematocrit around 25%. So this system also allows for multiple therapeutic interventions and also organ assessment by multiple means, and I will allude to this further down the road. So in contrast, static hypothermic oxygenation uses perfusion with hypothermic blood perfusate with steam solution at 8 degrees of Celsius. It's a controlled temperature system. The organ is non-contracting, inactive. The perfusate is otherwise, of course, oxygenated. And the default pressure is around 20 millimeters of mercury, unlike the normal thermic system where we try to maintain the target mean arterial pressure around physiological 75 millimeters of mercury. In this case, the allogenous blood is used for the system. So coming first to the normothermic perfusion, so let me highlight three major prerequisites of this system. It's ex vivo resuscitation of donor organs from the insult of brain or circulatory death injury. It allows for ex vivo metabolic and functional assessment and also significant reduction of ischemic time at the first and second ischemia are interrupted by the phase of physiological oxygenated perfusion. So the system is instrumented to the cannula and the ascending aorta, and this is the path of the blood across the heart to the while feeding the coronaries, going to the right atrium, ventricle, pulmonary artery and back to the reservoir and again and again recirculate it. So here should be mentioned that, and you can see it here, so both SVC and IVC are oversewn to close the system in this respect. So the system allows for multiple assessment of the heart in the, after the retrieval. So here you can see the beating system. This is the inflow cannula. And maybe let's rerun it again. So when it allows us to assess a contractility of the heart. Obviously, it's not objective. It's subject to individual bias, but gives us very good perspective how the heart performs within the system. So on the second picture, it shows the heart which has been discarded, which has not been used because there's been unrecognized on TEE internal damage of the heart after the car vehicle trauma. And basically, the heart would have been otherwise accepted and transplanted. So, and this device, given the fact of distant procurement, has helped us to identify this heart, which would be a catastrophe for the patient. So it also allows for optimizing all the parameters. Here you can see multiple parameters, obviously the heart rate, coronary flow, and also, as mentioned before, this is a mean arterial pressure as shown here. And all these parameters can be addressed and optimized during the support. And also it allows us to assess metabolic function of the heart. So the primary biomarker is lactate consumption. What we try to and wish to see is to see the plateau or decreasing lactate level, and also we wish to see the arteriovenous difference in lactate, so as a sign that the heart is metabolizing while having venous lactate lower than the arterial one. So, or in some circumstances, we can end up with this trajectory, which leads to the organ discard. So in summary, for the normothermic regional perfusion, so it can either increase and shorten the ischemic time in terms of cases of distant procurement and transportation. In marginal donors, it can help to recondition and reassess the eligibility of the heart. And in case of donation after circulatory death, it helps us to resuscitate and utilize the heart, which would have been otherwise possible to be used. And overall, basically the second one and third one ultimately expands the donor pool for the potential transplants. So, and I'm mentioning that because the opportunity is here, and these are US data showing the disparity between the number of deceased US donors and the proportion of hearts which have been utilized for transplantation in the United States back in 2021. So, and this basically shows the opportunity how to further expand the hearts by using these advanced techniques. So let me just mention regarding normothermic perfusion, one trial, it's called EXPAND trial. It's a multi-center single-arm trial of donation after brain death donor hearts in the US. The purpose was to evaluate the effectiveness of the normothermic oxygenated perfusion on preservation and assessment of potential donor hearts, which would have been otherwise suddenly used under conventional criteria. So it's a single-arm objective performance goal has been set based on the data and the registries with the optimal performance goal of 65% of the primary composite endpoint, meaning the survival of the graft, survival of the patient, along with the absence of primary graft dysfunction. So the inclusion criteria were basically set as the expected cross-clamp time beyond 4 hours or 2 hours along with any of these additional risk factors, the age, the absence of cath data. So as in the United States, there are many centers where locally the cath of the coronaries cannot be performed. And I just want to mention that in Transmedic system, the coronary angio can be performed while the system is in place and on ex vivo. It can be performed, so it's another key feature of the system. So, and based on that, you can appreciate that half of the patients have had primary +1 inclusion criteria, but the other half has had at least 2 or more of these additional risk factor criteria. So OCS has been used in very high range and utilization was 85%, which really showed that it has helped to expand the cake of the opportunity, and the reasons for turn down were typically based on the trend of the lactate, as I have shown before. So, and here you can see that in both cases, it has shown clearly non-inferiority to the optimal performance goal for the primary cohort and also for the extended cohort, including the continuous access protocol. So, and if we take a look to the complications, adverse events, here we can see that the severe PGD, primary graft dysfunction, was in less than 8%, and primary graft failure, which would necessitate retransplantation, in less than 1%. So let me move fast to the hypothermic oxygenated perfusion. It's a Swedish ex vivo system. The heart is instrumented again on the ascending aorta. It's a closed system which recirculates cold oxygenated perfusate. It's less resource intensive. It can be transported in a regular commercial plane, and also does not need a complete crew to manage the overall perfusion system. So, and let me just mention one trial. It's a HOPE trial, which has shown non-inferiority in patients who have been randomized between the conventional static cold storage and the hypothermic perfusion. Nonetheless, here should be mentioned that the reduction of significant graft failure was clinically relevant, with reduction of 44%, despite the fact it has not yielded clinical or statistical significance. So, and if you take a closer look, so here you can see the potential advantage by the significant reduction with hypothermic oxygenated perfusion, especially in the primary graft dysfunction of right ventricle and severe primary graft dysfunction. So this technology needs to be further studied. Nonetheless, we believe that it has also potential to contribute to the overall outcomes. So last but not least, let me focus on donation after circulatory death. So here you can see the US data with expanding numbers of transplant over the last decade. However, if we take a closer look, so we can see a marked contribution of donation after circulatory death to the overall numbers. In 2024, it has been estimated more than 800 DCD heart transplant in the United States, and the trajectory is still trending up. So the procedure is more complex compared to donation after brain death, and because after withdrawal of ventilatory support, so which is followed by anoxic period, so it leads to volume overload, fibrillation, and further down the road to the asystole. Then there is a standoff period of at least 5 minutes in most of the regulated areas, so which is followed by the procurement and storage, typically on the system for ex vivo perfusion, to resuscitate the heart to make it further eligible for heart transplantation. So I will mention again just one randomized trial published in New England Journal of Medicine. It's a multicentric US trial with a purpose to evaluate the effectiveness of the normothermic oxygenated perfusion Transmedics in DCD patients. And basically, it has randomized 90 patients with a control of DBD heart transplants, and it clearly showed that there was proven non-inferiority both in the primary protocol as well as in MITT cohort of patients. The utilization rate of these donation after circulatory death hearts was impressively high, almost 90%. And again, the primary reason for turning down was the trend in lactates. So coming to the outcomes, the higher incidence compared to DBD was reported in a domain of severe LV or RV primary graft dysfunction. Nonetheless, within the ecosystem of previously reported data, it's pretty favorable outcome. And if we take a look to the overall patient and graft survival at 2 years. So this data and Kaplan-Meier curve has shown the superiority of the performance in DCD donors even compared to DBD hearts. So with that, let me conclude that timely and comprehensive donor management remains a cornerstone of heart transplant outcomes. Expand heart trial as well as DCD trial, as shown here, met the endpoints and demonstrated that the use of OCS heart technology resulted in high rate of utilization of donation after circulatory death and also extended criteria DBD hearts for transplantation. Hypothermic oxygenated perfusion is definitely promising, less resource intensive technology in select indications. Nonetheless, we cannot at this time point assess objectively the performance after the circulatory death retrieval of the heart. Nevertheless, the technology is evolving both in normothermic and hypothermic perfusion, and there is a lot of progress in identifying perfusate biomarker-based triage, including microRNA, troponin T, and metabolomic profiles, which will help us further determine the performance in a more objective manner. And also ischemia reperfusion mitigation by adjuncts of pharmacological components, hypothermic flush, or antioxidant cocktails such as glutathione or ascorbic acid, which can further improve the performance in ex vivo perfusion. Thank you very much for your attention.